Got a yes. I'd like to let you guys know this is my first time doing a Zoom or a Teams presentation where I share my screen. So I'm a little nervous about this, but I'm assuming you can see my first slide that's titled Emergency Assistance, correct?
Yes, it's all good, Susan.
Okay, great. So Marie has asked me to give a presentation on this topic to your ER committee. I'm going to do that, but then I'd like to leave some time at the end for any questions or discussions you want to have, the members of your committee want to have, that I might be able to help out with or participate with. I am by no means consider myself really an expert in this area, but I do work in this area and I have learned a lot. So I've spent a number of hours in conversations with Marie and her emergency manager and some other people from CDPH talking about these topics, but I wanted to make sure we kind of were all on the same playing field in terms of understanding, because we do have some challenges and always in those challenges are some opportunities, but want to make sure that we all at least have a, kind of a unified understanding of what our situation is today to know where it might be that we can go into the future. So a little bit about my background. I currently work within CDPH's Emergency Preparedness Office. So we're kind of the coordinating office for all the emergency response, recovery, mitigation, preparedness planning that goes on relative to public health. We do have a Center for Environmental Health. I work very closely with SADA on issues that involve emergency response and environmental health. So we have kind of a long working relationship together. But I'm actually a consultant. So I work for different organizations, all state agencies, when they have a need for a specialized project that has to do with some aspect of emergency response, and usually either public health, environmental health, or healthcare services, hospital operations and things like that. So in my background, I've done projects, this is going to be quick, for CDPH, EMSA, Cal OES, Department of Healthcare Services, and the Coupa Forum Board, which I'll get to in a second. Most recently, I completed not really a guidance document, but a consideration document that updated a previous wildfire smoke a document that we had produced a few years ago. Bill Jones from the Coupa Forum Board hired me to develop a couple of plans they were interested in, one of them being the California Disaster Emergency Assistance Plan, or DEEP plan, that I think is posted on the Cal Coupa Forum website. I mentioned wildfire smoke, sorry I repeated that. I also work for Cal OES at times and CDPH currently on large radiological incidents, nuclear detonation type stuff. So I'm kind of all over the board. And then more specifically to the interests of this group, I help facilitate a group that's been meeting since 2005 called the Emergency Operations Manual, or EOM work group. That is an ongoing process. Marie is actually a member of this EOM work group. It's a very small work group that kind of focuses on real challenges that we're facing in our system for any kind of health response and recovery, and tries to solve some of those problems. So they're kind of like a mini think tank for solving some of these issues. But as you can imagine, COVID has really taken the wind out of our sails for the last 2 years. Effectively, almost everybody in my group, at least in my world, has been redirected. So there's been a little bit of a pause on that. But two of the primary areas that we will be working on, hopefully the beginning of the year, will be resource typing, which will relate to this conversation, and a more detailed health and medical assistance plan. So I'm going to fly through a few of these slides. I just want to mention that there are legal authorities that always form the foundation of what we're able to do in a disaster. The main one would be the Emergency Services Act, quite a lengthy statute that has a lot of information in it about who's in charge, under what circumstances, what kind of disasters can be declared, that kind of information. Then the California Disaster Assistance Act talks about, you know, how people might be made whole if they're spending money associated with disaster response. And the one I'm going to focus on for this presentation is a document that I think, an agreement that was prepared a long time ago, like in 1950, called the California Disaster and Civil Defense Master Mutual Aid Agreement. And that's a long title, and we usually just refer to it as the MMAA. So when we talk about the concept of mutual aid, which is a form of emergency assistance, people often point to this and say, every political jurisdiction is signatory to that. Every city, every county, all of the state agencies are required to comply with it. So the Master Mutual Aid Agreement is really an integral element of the law of the land for helping jurisdictions out if they're in trouble. But there are some problems with it, and I'd like to point out the problems with it. So this is direct language from the state emergency plan. And it basically says that the broad topic of emergency assistance is based on a statewide mutual aid system designed to ensure that additional resources are provided to any subdivision when their own resources are either overwhelmed or inadequate. And the basis is this Master Mutual Aid Agreement, but here's the kicker. The agreement obligates each signatory to provide aid to each other during an emergency if they feel the aid is available, and there must be no expectation of reimbursement. That's the kicker for the Master Mutual Aid Agreement that makes it difficult to apply often in our situations where we get overwhelmed and we need assistance, because it has become increasingly difficult for people to provide resources without an expectation of being made whole, right? Without getting reimbursement for the cost of those resources that they're providing to another county. And we'll come back to this in a minute. So the state emergency plan also acknowledges that the Master Mutual Aid Agreement isn't necessarily the fastest game in town, because it follows the levels established by SEMS, by the Standardized Emergency Management System. So it begins at the local government level, then it goes to the operational area, then it goes to the mutual aid region. Then after that, it would go to the state, and then eventually it could even go to the feds, or it could go via EMAC to other states. The bottom line that I'd like to emphasize is that in theory, it should happen pretty quickly, but in reality, it's kind of a slow process for the most part. So the state emergency plan, I think, wisely encourages jurisdictions to establish their own emergency assistance agreements, and whether that includes public and private sector agencies, they don't care, but they urge that we develop those agreements and not simply rely on the Master Mutual Aid Agreement. So mutual aid agreements or assistance agreements come in many different forms, but they're generally written agreements among agencies that provides a mechanism, and I emphasize, to quickly obtain emergency assistance, whether it's personnel, equipment, materials, and other associated services. Because again, the Master Mutual Aid Agreement tends to be relatively slow. And then if a group, if a discipline decides they are going to develop their own mutual aid agreement specific to them, or an assistance agreement, they generally are going to need coordinators at the major levels to actually do the work. You know, it doesn't just magically happen on its own. So a mutual aid coordinator could be an individual, possibly at the local government level, but certainly the op area, the region, or the state, that would be responsible to, you know, be involved in the requesting, the obtaining, the process, tracking, and the utilization of those resources. So the person who ends up being that mutual aid coordinator depends on the mutual aid system. So back in 2009, Cal OES decided that our state was so large and we had so many emergency, you know, impacts that could occur. They wanted to sort of get their arms around it and control span of control, essentially, by saying, let's kind of bring everybody in and divide it into 18 primary response activities. And we're going to call those emergency support functions. So it was modeled after the federal system that came before this. So this is just a quick snapshot that shows you we have 18 of them initially. A couple have been combined together since then. I'm not going to spend much time on this, but just to point out, if you look at ESF 4, Fire and Rescue, the lead agency in charge of that ESF 8, that ESF is Cal OES. If you look at Public Health and Medical, drop down to 8, that would be our California Health and Human Services Agency, but they have, because they're not as operational as CDPH and EMSA are, they've delegated it to us. If we look at ESF 10 Hazmat, that's Cal EPA is in charge of that. And this is true for all 18 of these various functions. So let's talk about the real issue here that I think sort of causes a lot of headaches for us, is that, you know, in the upper left-hand corner, we have a great example of silos, right? They're concrete structures. We tend as disciplines to get into groups like this, and we start saying, you know, I'm here with my people, we're doing our thing, whatever it happens to be, public health, environmental health, EMS response, and we're going to keep those other distractions out, and we're going to develop a system that's really going to work for us. So we have a tendency to do that, and there's plenty of benefits from that. You know, we can be focused. The problem becomes when we all work in our silos, which we do, me included, we may get to a point where we have a big problem on our hands and we really need some help from a different silo, right? 3 silos over. Well, the way we've structured them, it's really hard to get that assistance from that different silo. So I'm a swimmer. I love to swim, and a scuba diver. So that's why I've put this picture of a swim pool here with lanes in it. And I think we somehow have to figure out a way to transition from the grain silos to more of a swimming lane approach, where we're in our lane. We need to be in our lane to develop whatever we're working on. But there has to be some ability to communicate with and understand what people are doing in other sections of the pool. So let's get back to mutual aid systems. There are 4 that I'm familiar with. I'm not saying this is all of them, but these are the 4 formal systems that I am familiar with. And I've broken them down by ESF. So ESF 4 is Fire and Rescue. The lead agency is Cal OES, specifically their Fire and Rescue branch. And they have a very robust mutual aid plan called the Fire and Rescue Mutual Aid Plan. Very robust. Developed it under Fire Scope a long time ago. Obviously, the fire service are responding all the time. They use this daily. It's part of their everyday operations, and it certainly works very well in a disaster. In fact, it became the model for our standardized emergency management system and then the nationwide NIMS. So credit to them. They developed one hell of a fire and rescue mutual aid plan. And there is a lot of administrative overhead that goes in maintaining that plan toward that. If we come down to ESF 5, that's emergency management. That's run by Cal OES. And many of you have heard about the Emergency Management Mutual Aid Plan, or EMA, that is meant for sharing resources that go to docs and EOCs. So really emergency managers, not tactical response personnel. The third one I wanted to discuss is Public Health and Medical, again, led by the California Health and Human Services Agency, but sort of delegated to CDPH and EMSA. And we, that's our group, we sort of oversee a public health and medical mutual aid plan that does not formally exist in a plan. I'm actually writing that, but it is referenced in a document we have called the Public Health and Medical Emergency Operations Manual, or EOM. And it's referenced in the state emergency plan. We use it, and I'll talk about that in a little more detail. The last ESF that has its own mutual aid system that I'm aware of would be law enforcement. And under that, they have 3 mutual aid plans: a law enforcement mutual aid plan, they have their own search and rescue plan, and a coroner mutual aid plan. So the point that I'm going to be making is that when resources are contained in one of these systems, it is very difficult for a needed entity that comes from another system to access their resources. And the reason is because there are signed agreements in place where people say, for example, with the fire and rescue mutual aid system, they basically are paid portal to portal. So those individuals, might get deployed under their mutual aid plan. And when they show up, even if they're working 8 hours a day, but they've been deployed and they're back at their hotel, my understanding is they're being paid for the whole time they're there. So some people in other systems may not want to agree to those terms. And also, we don't have anything written between us at the time. So just to summarize, requests follow discipline-specific chains. An example would be fire and rescue or public health and medical, from one level of government to the next. All of the ESFs don't have their own mutual aid systems, only a few of them do. So if they don't, they generally tend to go to their emergency management agency that is there in their op area. So, but for all of these mutual aid systems, they all have their own specified procedures, the way they want it run. And again, are processed through these pre-identified mutual aid coordinators. And I'll speak about ours in a minute. Typically, the mutual aid coordinator, usually beginning at the op area, receives the request and then coordinates the provision of resources from within that coordinator's geographic area of responsibility. So if you're the op area coordinator for fire and rescue, you would look within your operational area. And if that's unsuccessful, then they go to some kind of a regional approach. So whenever resources, that's why I say this isn't the fastest process, whenever resources are unavailable at one level of government, then SEMS promotes moving forward to the next higher level of government to be filled. Okay, so focusing on our system, ESF 8. I have on the left the SEMS level: field, local government, op area, mutual aid region, and state. And then if we look at the coordination function, our system has no specified coordination function at the field level or local government. That would be all the cities and the independent county, the counties, special districts, school districts, whatever. We don't have the staff to do that. So our coordination function begins at the level of the op area. And I think we're all familiar with the fact that the op area is a SEMS feature of disaster response. So we have what's called a mohawk program in every single one of our 58 counties. And if you don't know what mohawk is, I'm going to get to that in a moment. We have as our coordination function an RDMHC program, which includes a person called an RDMHS within each one of the 6 mutual aid regions. And then the level above that would be the state level, where both the CDPH and the EMSA duty officer programs manage that resource issue. And if our EOC is activated, called the Medical and Health Coordination Center, then that function of supporting resource management for the incident they're activated for would then switch over to the MHCC. So let me just explain. I went to the annual CCDEH conference, like, I don't know, 7 or 8 years ago with Marcy Barnett, gave a presentation to the whole group. And I think we asked how many people knew what a mohawk was. And a very small number of people raised their hands. So this, I think, is much higher at this point, that there's familiarity with it. So for ESF 8, at the op area level, the Medical and Health Operational Area Coordinator, or the mohawk, is a position jointly appointed by 2 people, the county health officer and the local EMS administrator. Now that's one person, but we acknowledge that it's a many different functions and responsibilities fall under, ESF 8. So they can't do it by themselves. It's an unpaid position. So they basically have to build a program that sees to it that all of the 17 functions described in the statute are being addressed by their response program, by their mohawk program. If we go to the next level, which is the mutual aid region, we also have an appointed regional disaster medical and health regional coordinator. This is voted on by a bunch of people in the counties, and then they're jointly appointed by EMS and CDPH. The person we call the C is really the figurehead, the person in charge of the organization. The person you would interact with is the same term, regional disaster medical health regional, but specialist instead of coordinator. So the RDMHS is a staff support position funded equally by CDPH and EMSA. And we traditionally had one RDMHS in each mutual aid region. That's changing because we were basically breaking them right and left because the workloads were so high. And so now most of the regions have more than one RDMHS, they have two. And then at the state level, that function would be handled by either the duty officer programs or if it's activated, the MHCC. So kind of bringing this to the point where we talk about stuff, the challenges or opportunities, I think, are we have a lack of familiarity among these different disciplines. If we don't day-to-day work in that discipline, and then we need resources that they happen to have, and we want to try to bring those in a disaster response, it can create challenges. Mutual aid in general is a kind of slow stepwise process. But there's another alternative for a county in need or a responder in need to get help. And that's if when that resource request goes into the system, and if Cal OES sees it, and they recognize that a state agency might have the technical expertise or the resources that are being requested, they certainly have the ability, Cal OES does, to mission task a state agency. They can't mission task any local jurisdictions, but they sure as heck could mission task CDPH or Cal EPA or groups like that to do certain things. And then if that state agency can do it and push out the resources to those in need, honestly, it's a fast way of getting resources, but it can also create some confusion. Because there have been examples, they're not textbook, but they've happened, where a request for resources came in at a local government level and started moving up the SEMS chain, and perhaps had reached the RDMHS, who had located the resources in the region and was undertaking the process of getting them to the party in need, but they weren't aware that Cal OES had mission tasked the state agency to do the same thing. So sometimes we've had examples where the resources show up twice because both the systems were being employed at that time. Money is always a factor. It's not something where I have spoken to people in the past where they said, we don't shore up our response systems that much because if we get it, if an unexpected thing happens, we'll just yell for mutual aid and free assistance will come. That's becoming less and less likely. I would say almost unheard of at this point in time, but not impossible. Money is a factor. Always keep that in mind. People want to be reimbursed. And where this gets problematic and where I most engage in discussions with Marie was, she was struggling because she recognized as a separate environmental health department, not under public health, right? Standing on their own, as is true for, I don't know, maybe half the counties in California. She found herself in a position where she really needed and wanted resources that were held by a different mutual aid system. Now, I think at first, we might have thought those resources were in the ESF 8 system, but they actually weren't. They were in the fire and rescue system. So just to give an example, so for this example, the environmental health department is distinct from the public health department. And normally for many environmental health departments, they typically work with their local emergency management agency, their local OES, whatever it's called, to obtain disaster resources on, the rare occasions, before the last 5 years when they were needed. And so in that situation, it may be that the people, in the environmental health department are relatively unfamiliar with our ESF8 system, where the mohawk and the RDMHC functions reside. So when a disaster occurs, in this particular example that Marie and I were talking about, she was interested on behalf of her environmental health department in accessing resources that were actually in a CUPA that was within a fire agency. And that even takes it out and away from us, right? That falls into a fire and rescue mutual aid system. We can't access those resources. I'm not aware that other mutual aid systems can, because those resources fall within their fire and rescue mutual aid system, which is housed under ESF4, and they have their pre-established salary surveys, agreed upon procedures. So unless we become somehow signatory to their agreement, we don't have any agreement in place to bring those resources into our system, even though we may need those resources. So we have had discussions about how might we be able to bridge this gap so that we can shape a workable solution. We don't have those resources stuck in a silo that there's no way we can get to when we need them, perhaps to save lives. How do we get more to a swim lane approach? So I just want to mention that for those of you that don't use the ESF8 system, that do go through your local emergency management agency, I'm all for expanding those connections. So we don't tell local jurisdictions in any of our written documents, what to do at the local level, how to organize, and we acknowledge that local policies and procedures really vary a lot throughout the state of California. But establishing a relationship with the county's mohawk program before a disaster occurs is probably a really smart and good idea if you don't have that already. You may want to look at the public health and medical EOM, because it does describe the procedures that are used for both situation reporting and requesting resources. But it's all based on relationships. You really want to know who your mohawk contact is and RDMHS to kind of improve your ability to access those resources. And then our aim is to develop practical solutions that improve our ability to access resources that are maintained by different groups. But I think we all recognize that pretty much any major disaster becomes a public health and environmental health disaster. We're involved in everything now. So if those resources are being held somewhere else, can we work together to come up with some mechanism for sharing it? Anyway, that's the end of my presentation. I don't know if you guys have any questions or not.